we chose to focus on the most common endocrine issues affecting surgical patients: diabetes, thyroid disease, and the role of perioperative stress dose steroids. We have summarized the available literature and guidelines and also included the recommendations from endocrinologists at our institution. Hello, I'm Karina Himes. I'm an assistant professor of medicine in the Division of General Internal Medicine at Mayo Clinic in Rochester, Minnesota. Our article in Mayo Clinic Proceedings is titled Perioperative Evaluation and Management of Endocrine Disorders. And this is part of a larger series on perioperative medicine. So I will highlight some of the key takeaways from this article for you. Starting with diabetes, we know that patients with diabetes have increased perioperative morbidity and mortality compared to patients without diabetes who are undergoing those same surgeries. It's been shown that perioperative glucose levels on the surgical date and those first few postoperative days correlate with perioperative complications more strongly than preoperative hemoglobin A1C levels. And the target glucose range is 80 to 180 milligrams per deciliter. Tighter glycemic control is not associated with better outcomes in these patients, but is associated with increased rates of hypoglycemia. Now, as far as medication recommendations, non-insulin diabetic medications should be held the morning of surgery and typically can be restarted once the patient is eating normally. The main exception to this are the SGLT2 inhibitors, which should be held for 3 days prior to surgery. And this is to avoid the rare complication of diabetic ketoacidosis. Recommendations for preoperative insulin differ based on the type of diabetes, the type of insulin, and the patient's predisposition to hypo or hyperglycemia. In tables 2 and 3 of our review, we break this down for you and give insulin dosing recommendations for the day before and the day of surgery. Now, moving on to patients with thyroid disease. Patients with subclinical hypothyroidism or mildly reduced free thyroxine levels don't have increased perioperative risk, and it is safe to proceed with surgery. On the other hand, patients with severe hypothyroidism, and particularly patients with mixed edema coma, are at very high risk for perioperative cardiac and pulmonary complications, and surgery should be deferred. If urgent or emergent surgery is needed in these patients, they should be started on IV thyroid hormone replacement right away. Now, for patients with hyperthyroidism, it is recommended that elective surgeries be deferred until the patient is euthyroid. And for urgent or emergent surgeries, these patients should be pre-treated with beta blockade, antithyroid agents, and corticosteroids. So finally, which patients should receive perioperative stress dose steroids? This is a controversial topic, and the evidence is very limited. The need for stress dose steroids is determined by the invasiveness of the procedure, the dose and duration of steroid exposure, and testing of the hypothalamic pituitary adrenal axis if needed. We recommend giving supplemental steroids to all patients with known adrenal insufficiency, and also all patients who have been on doses greater than or equal to 5 milligrams of prednisone daily for over 3 weeks within the past 3 months, and also patients on high dose inhaled corticosteroid therapy. So in summary, surgical patients with endocrine issues require special consideration in the perioperative period. For diabetes, remember, the most important thing for these patients is ensuring that they remain in that target glucose range in the perioperative period. For thyroid disease, surgical plans only need to be altered if the patient has hyperthyroidism or severe hypothyroidism. And the evidence for stress dose steroids is very limited, but we do recommend them for specific patient populations with chronic steroid exposure. So I hope this review helps give you a framework for how to approach these endocrine issues in the perioperative setting. Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.